Well, welcome to this episode of HIPcast. Today we have Ketyra Clayton, also known as Casey. If you look her up on LinkedIn, she's under Ketyra, Ketyra Clayton, but she likes to go by Casey. Casey is going to talk with us today about ARC, or the Agency for Research and Healthcare Quality, and some patient safety indicators from ARC that CMS adopted. And we'll just talk through some operational components and maybe some logic behind why we are leveraging weighted patient safety indicators in healthcare today. So Casey Clayton is the Commercial Deniers Coordinator at Forest General Hospital in Hattiesburg, Mississippi. She reviews commercial payer and Medicare Advantage Plan DRG downgrades. She began her career at Forest General Hospital in 2017 as an HIM specialist in the operations area. She transferred to coding and clinical documentation integrity in 2019, where she quickly rose to the position of denials coordinator. She's also an adjunct instructor at William Carey University in their undergraduate program. She received her undergraduate degree in health information management from William Carey University, and she obtained her RHIA credential in 2016. She received her master's degree in public health, way to go, Casey, with an emphasis in health policy and administration from the University of Southern Mississippi. She's currently seeking a doctoral degree in healthcare administration from the University of Mississippi Medical Center. Again, way to go, Casey. Casey currently serves as the Mississippi HIMA Board of Directors as the first-year delegate and sits on the Advocacy Committee. She is also the chair of her local Pine Belt Council. Casey is a Christian and an active member of Jerusalem Missionary Baptist Church in her hometown as a youth leader, announcement clerk, and hospitality committee member. Well, Casey, welcome.
Thank you. I'm happy to be here this morning.
Yeah, we're happy to have you. I have only met you just this morning, and I can understand easily why you're part of the hospitality committee. You're wonderful to talk to, warm and welcoming. So
Thank you. Thank you.
I do the standard Baptist thing. I'm like, why are you sitting in my seat? That's my seat. I'm
Well, I did assign myself a seat on the 5th pew at the end, so I can kind of see the pastor, but I'm still close enough to the back of the door where I can just ease out after service is over.
Yeah, my wife knows that I'm a creature of habit. Like if somebody's in our seats, I'll leave Sunday school a little bit early to go put some stuff down on my seats because I got to sit on the end and I got to sit in a certain section. I know that the air conditioner's not blowing on me here. It's like it's my little place, and I don't want to be too close to the fire when the preaching's happening. I got to sit towards the back, but
that's right. I just need a couple embers. That's all.
I just need a little bit of heat, but I don't want that fire. I don't want my toes stepped on. So I love that.
Before we get started going through the interview, I'm curious, Seth and I lovingly refer to our dear friend as Mississippi, Lori Mills. I'm assuming you know Lori very well from working at Forest General.
Yes, I do. When I transitioned to coding and CDI, she was our director at the time when I transitioned. So I worked. We also worked all in the same department at one point in the hospital for about maybe 6 or 8 months. Then started moving everyone out. So I've known her since 2017, and she is a blast.
Oh yeah,
she's a blast.
We love her. She's always invited to Tennessee functions.
Yeah, and I'm the one that renamed her. A lot of people know her as Lori, but most people around the country know her as Mississippi. Because I'm like, I'm not calling you Lori, I'm calling you Mississippi. So, all right. So I was looking at the outline as we prepared for this episode and this interview and to talk to you. And we're talking about, as Shannan mentioned, the Agency for Healthcare Research and Quality, some of the CMS stuff, PSI, patient safety indicators. I looked at PSI and I was like, how much PSI does my tires take? That's about what the extent of it. I live in the IT world. So to me, this is going to be very educational. I hope our audience is going to really learn a lot about this, especially those of us that don't live in this environment. So tell the audience about the Agency for Healthcare Research and Quality and kind of the CMS tie-in with the history there.
Okay. Well, the Agency for Healthcare Research and Quality, they reached full agency status in 1999, I believe, or maybe a little earlier from the U.S. government. So they were charged with helping hospitals increase patient safety across the country. So and then we had the Institute of Medicine's report the to err is human. So that kind of alarmed everybody, and it let everyone know that it's not bad people, but it's good people working in bad systems. And so the Agency for Healthcare Research and Quality, they were tasked with helping hospitals increase their quality rating and through different patient safety indicators that they have modeled since 2000. So CMS comes in because they were concerned about their patient population, and they wanted to increase their safety and quality of care. So they adopted some of some of ARC's PSI 90 indicators and kind of tweak them to fit their Medicare population, because let's just be honest here, we're not going to have any newborns or any pregnant women on Medicare. I hope not. Hope not.
Right.
Right. It is possible, because I think my great grandmother's baby daughter had her first child at the age of 50. So,
whoa!
And her mother was 51 when she had her last child.
I hope it's done certainly at that age.
I told my mom, I'm like, me and the baby in diapers? No, this is not going to work. That's not going to work. So it is certainly possible, but we hope not. So and they started it's part of our hospital's HAC score, or our hospital, what's it called? I can't remember. Hospital acquired conditions score. Mm-hmm. So that's part of it. And we do have, every PSI is weighted separately, differently. Our highest weighted PSIs are going to be your postoperative respiratory failure, postoperative sepsis. It's going to be your PEs and DVTs for obvious reasons. Lesser weighted and pressure ulcer rate. Your lesser weighted ones are going to be like your accidental puncture laceration, your wound dehiscence, all those kind of things. It's what they really entail is preventable conditions during a hospital stay. And I did speak with Dr. Paul Romano. I actually ran into him at the AHIMA's Hill Day earlier this year. And I was talking to him about some things, and he said we don't take into account a specific patient, but it's like in that global period. So if that patient had not had that surgery, would this complication have happened? So that's a different way to look at it. So it's holding providers, clinicians responsible for the care they provide their patients. And I know, and we all know that sometimes it can't be avoided. Sometimes some of these things, they're just going to happen. If you have a patient with COPD, they're going to take longer to come off the vent. They may need to go back on the vent to actually recover from if you crack somebody's chest open, it's going to take some time for them to recover. We know this, and sometimes even we can offer the best care that we have available. Sometimes then they still happen. These things still happen. So but we're trying to minimize that as much as we can by going through the data, talking to our clinicians, providing education, and we also try to involve our C-suite at some point, because they actually came to us. They were like, well, what's going on? What is this HAC penalty? Why are we getting penalized? What are these PSIs? Because they knew about them in like an overview of them, but they didn't know how much they affected our hospital's quality score overall. So that's where the coding and CDI department came in. Normally it's your quality department that takes care of all this, but our CFO and CMO, they were like, we need to get a team together here. So they called on HIM, and we stepped up, and we're helping quality out with the monthly quality reports that we receive from them. We also have a different workflow that we look through are the patient still in-house in real time or right after discharge. And we've actually made a significant improvement in our facilities HAC score. And for the first time in 2025, we do not have a HAC penalty. So this is our first time. So thank you.
Yeah, that's a lot of work to be able to get to that point, and a lot of management and understanding, the relationships between the clinicians and the management of it and the documentation of it. And so is the weighted piece, you mentioned the, and again, I'm learning all this stuff, right? I probably should have this in my yearly CEUs, but the weighted piece, it's weighted as to help out because there are certain people that may take longer, as you mentioned with the COPD, right? So
Right.
you can't just do a blanket rule or a blanket stat. It's got to be weighted to allow that flexibility because people are different, right? People respond to different treatments and have different things. Am I understanding that right?
Yes, you are. They I think the Elixhauser model is what they use on the ARC and the CMS side to calculate the risk score of these patients because they have access to our claims data. So what they do is they take into account this patient, all their comorbidities, and they weigh them and they use the Elixhauser score model to kind of subtract or give us a little more grace, I would say.
Gotcha. Yeah.
In that PSI score. So but
it sounds like a perfect spot for an HIM person.
It is. Right? It is. And actually it's we're learning now because we're still doing a lot of research on it as well. The CDI department or your clinical documentation integrity department, they are actually the ones that are tasked with this in some other facilities. But we take a team approach at Forest General, and it's more so like our quality department, coding, and CDI. Because our CDI understand that they understand the POA piece. They understand the ADT orders better. Like they're looking at when did this patient come in as inpatient. Now we've had situations where a patient will come in for an outpatient procedure, and they will have a complication. Well, that complication may be a PSI, but their PSI is actually present on admission when they come in because their status has changed to an inpatient status because of that complication. So, and then if they don't catch it, like if they see the patient first and then it's out the door to the coder because the patient is now discharged and they don't get a chance to do a re-review, well, they may have it as not present on admission, but our final coder will go back and they'll change that to a present on admission status. But there's, they catch it 9 times out of 10, they will catch that and change it to a POA of why. Yeah. And then we do have instances where we're just not really sure if it is present on admission or not. And in that instance, our CDI or our coding team will query our physicians to ask them if they're present on admission. And what we actually want them to say yes or no. But if they're truly also unable to determine and they document that they are clinically unable to determine, we can use a W to not get a PSI because it's not present on admission or is not present on admission or it's not present on admission. It's not actually defined. But if you use a U, that means that it's not defined as present on admission or not, and you didn't ask. So that's still going to penalize you if you use that U indicator. But if you use the W, then it won't. And we are very sparing in the use of that W. Trust me, because we don't want OIG or anyone else saying, "Hey, look, this doctor has great scores, great percentages. Let's see why he has such
all W indicators."
And then it's like, "Oh, everything's a W. Oh no, this is an audit." So we're very prudent in how we use that. So. But it's still a learning process for us all, basically, and we're just enjoying the ride right now.
Yeah,
that's awesome. So I have a couple of maybe one follow up, and then I want to talk a little deeper about weighted PSIs, if that's okay. My one follow up is, what do you think was the turning point that helped Forest General get to having no penalties for 2025?
I think it's more. I think the turning point was not looking at each department as a silo, but bringing us all together in a collaborative effort. Because quality they look at every PSI from CMS to commercial payers. They look at self-pay plans. And it's a massive undertaking, and they were doing it basically themselves. And so while they did the best, they did the best that they could, but sometimes some things just get missed. And so by bringing in the coding and CDI team, we actually help them. We actually offload some of that weight on them. So we're looking at them on the front end as well as the monthly quality report. So those that are on the quality report, we've 9 times out of 10, our department has already looked through them. We've already said, hey, look, there's no way we can exclude this patient. It's going to be a PSI. It's going to come back on the Crimson data in a couple of weeks, and then and maybe by then we'll have some more information and we can get a fresh look at it, and something may change. So it's just that collaborative effort between both departments to make sure that we're doing everything we can on the front end to code it correctly. We're doing their quality's doing everything they can on their end to make sure it's actually a PSI. They're asking us questions. We're asking them questions because, again, we're not quality. So what they go through every day is not what we don't do that every day. We don't read through those, the art inclusion and exclusion criteria. We don't know it like the back of our hands. Yeah. They do. We know the POA indicators. We know what present on admission is. We know the clinical indicators to say, hey, look, is this really going to be a penalty? Does this case really meet? And we're looking for the fine print. Like we have found stuff in an op note where the doctor says this patient has a coagulation disorder or a bleeding disorder. Hey, look, this is an op note. Is there any way that we can translate that into a code? Can we get him to say that on a query? Can we change this? It's the way we have it coded. Can we change it? So they don't know the coding side. We don't know the quality side, but us working together, we were able to get that, to be able to get our rates down and not get a penalty for 2025. So they work with us very well. We work with them. We ask each other questions all the time, and we communicate. We communicate almost weekly. So
it's a team.
Awesome.
So it's a team effort.
Agency and collaborative. I love it. Seth and I had a recent conversation with a guest about the necessity of having the different people in the different roles to talk through. And Seth talked about a statistic. What was it? 4%, Seth.
It's called the iceberg of ignorance, right? We all know our 4%, the 4% that's above the water, right? But so we have to come together as a group to bring our 4% together to get the full picture and to march towards the end goal.
I like that.
Yeah. Iceberg of ignorance. I don't know who coined it, but whoever it is, they can be a sponsor next time. But
I wonder, they may have been on the Titanic.
Yeah, exactly.
That's good. So Casey, tell me a little, because I've been out of the hospital world for quite a long time now. Tell me a little bit about the weighted PSIs and the provider level indicators that are included in hospital acquired condition scores. Talk a little bit about that and teach us what we need to know about that.
There are 10 provider level indicators, and they range from, I'm going to try to do this off the top of my head because my notes are not by my desk, but I'm trying to do this by the top of my head. All right. PSI 3 is going to be your pressure ulcer rate, pressure ulcer rate. I can never get those words out.
Yeah.
That's your PSI 3. Then you have PSI 04, the death rate among treatable conditions. That has been removed by CMS because they feel it's not a fair statistic. So they're moving toward a more claims-based statistic that they'll roll out probably within the next year or two. To get a more accurate picture of those deaths and that patient there. So I thought that was really cool. I saw that a couple weeks ago. Your PSI 6 is going to be your iatrogenic pneumothorax. PSI 7 is going to be your catheter associated UTIs. PSI 8 is going to be your in-hospital fall rates. PSI 9 is your post-op hemorrhage and hematoma. PSI 10 is going to be your acute kidney injury requiring dialysis, post-operative acute kidney injury requiring dialysis. I'm sorry. PSI 11 is your post-operative respiratory failure, which gave us nightmares. PSI 12 is going to be your post-op perioperative DVT and PE. 13 is your post-operative sepsis. 14 is your wound dehiscence rate. 15 is your accidental puncture and laceration rate. I got them all.
That's good. Wow,
that's all 10. That is all 10. And so your highest weighted ones, like I said earlier, are going to be your PSI 11, which is going to be your postoperative respiratory failure, your postoperative sepsis rate, your PEs, DVTs, and your hemorrhage and hematomas. They're going to be your top ones. And your laceration rates, your puncture lacerations, and your dehiscence rates, they're lower weighted. But if you have a lot of those low weighted PSIs, it doesn't matter if you have one of those post-op respiratory failures. But if you've got 15 punctures and lacerations, that's going to still increase your score because a lot of the little ones add up, and they add up quickly. So, and I'm thinking that we don't have a hold on PSI 11 and 13 yet, but we have it under enough control to where we're not being penalized for it this year.
Okay.
So and I think
things you're watching and trying to improve on, but they're not currently causing you any kind of penalties, but your patients will be better served with better outcomes, right? So
yes,
clinical quality together, clinical components with the quality requirements, driving Forest General to a place of no penalties for 2025, which is incredible.
It is.
Shannan, it makes
incredible.
me think that this is something that we should do a better job of as a profession in advocating and educating the patient population, that there's a team of people like Casey and the whole team of folks at Forest General that are focused on improving the quality of care for their patient population and to feel comfortable with the quality of care at that particular facility. Because I'm sitting here going, I remember some of these terminologies from back in the day when I was in the traditional HIM role, but yeah, it's bringing back some things of like, wow, if I knew in a digestible way as a patient that my local health system had folks like Casey that are doing this every day, it's like, all right, they're actually trying to improve. They're trying to produce a safe environment for patient care to reduce complications from procedures and give me more comfort and confidence that I can go seek care.
Man, that's good. Remember Dr. Shannan Harris and her passion for advocacy for patients to understand how to navigate through the system? This would align with exactly her passion, to be able to say, here's an easy way to express. If she created the curriculum to say, here's an easy, or just the whatever, the collateral that says, here in Forest General, here's the easy way for patients to understand inpatient, consumer-friendly terminology. These are the steps that Forest General is taking to make sure your outcomes are driven by quality care as much as possible, right? It's a great opportunity to bring together that passion for advocacy that you're talking about, Seth, with actually superstars like Casey, who are working collaboratively with clinical teams and with quality to make sure you get the whole picture and everything is considered so that you address it before that person leaves. That's a big deal. You're right. I think it's a great advocacy opportunity.
And I mean, I don't do it alone in my department. I lean heavily on my CDI team because they're mostly retired nurses, or they're still keeping up their nursing credentials. They're just off the bedside, and they have a wealth of knowledge that they do not mind sharing at all. We're like we call ourselves like a little village. It's like we always try to help each other the best way we can. If we don't have the answer, then we know someone that may have the answer, or we'll look it up and we'll sit and we'll figure it out. We will sit there until we figure it out. And no one is they're not stingy with the information they know. Whatever I ask them, they're free flowing with it. It's just a great community to have, and I just could not be in a better place. And I owe all that to my past director, my current director, management, the CDI professionals that we have on board. It's just an amazing department to be a part of. And I'm just thankful. I just thank God that he placed me there with them, and from 2017 to now. So, and on into the future. So I enjoy working with them, and they're a big help in this quality initiative we have going on.
It's kind of the unsung hero department in my mind that it's kind of developing out in the cartoon that is in my brain. That you don't get the accolades, you don't get the public knowledge that you guys are working it day in and day out on trying to improve the quality of care, looking at just the most minute details, just as you mentioned, going through the PSIs of ulcers, of respiratory things, and how do we change this and how do we affect that from clinical care to reduce that score. And kudos to CMS for bringing that in and wanting to include that and doing these scores. I always hear people talk about the hack scores, and it's normally negative, right? They hate it because they have to do all the reporting and whatnot. But the reality is, we're trying to improve the outcomes for our patients in this country. We're trying to make it a safe environment where you can get the intervention that you need. And there's a team of people back there that's looking at every little detail to figure out how to make that safe for me, for my mother, for my kids, for my family members. There's people that are in the basement of the hospital. I don't know if HIM is still in the basement, but we used to be in the basement with no windows. But there are people that are, not at the forefront of healthcare, the healthcare heroes that are the traditional ones. But you guys are doing a great work to improve the patient population and the ultimate outcomes for your patient population. But I do want to ask a question, I guess a final question here of, you mentioned the C-suite earlier. And you talk about the team. The team is very important from what's in your immediate area, but what roles does the C-suite play in helping drive that process through the organization and encouraging involvement?
Your C-suite, they set the goals for your hospital or your healthcare system. They look at the data that they get back from CMS, from our commercial payers. They look at those contracts, and they feed off each other. It's not like your C-suite isn't in a building by itself and they don't talk to other C-suites at other hospitals. That's ridiculous to think that they don't. They do. So they're very our CFO and our CMO and our CEO, they're very hands-on in our quality initiative. Why? Because they have to report to our board of trustees. And and it's not because they just want to not get in trouble with our governing board. It's because they really care about the quality of care that we're putting out to our community. And so when our CFO when he got involved, he was like, what is this? We need to figure this out. We need to get better at it. Okay, well, let's do that. He called quality to the table. He called CDI and coding to the table. We all came together and we created a team of people that were going to work together to get these numbers down, to make sure our quality got better. And we also we report to him every month, and him and our CMO every month. And our CMO looks at these cases and he's like, go back to this case. I want to give me the patient ID number. Give me all the facts. Give me all the specifics that you have, because I need to go back to my clinicians. I need to ask them what the thought process was. What could we have done better differently with this particular patient who had several comorbidities, but because she wasn't in there for any respiratory issues, she had to go back on the ventilator, and he wanted to know why. He said, I had to pull it up for him. He's like, well, why was she taking off the ventilator so early? Okay, this may be an issue. Maybe it was a miscommunication to extubate the patient so early. I need to know what happened. So they dig into the patient chart. They dig to try to find things. Okay, how can we improve this? How can we improve that? What process needs to be changed? What are our floor nurses doing when you see a patient come into the ED? Are they really assessing these patients from head to toe? Are they turning them? Are they looking for pressure ulcers? Are they looking for broken down skin? Do we have anything that could be present on admission that could indicate, hey, look, maybe you need to look for this pressure ulcer. Is this a nursing home patient? Do they turn them every 2 hours? Sometimes it can't be avoided. Sometimes they stay 60, 70 days, even though you turn them every 2 hours. You're doing everything correctly. It can still happen. But we need to be sure that we're doing everything we can on the front end. And that's what our CMO and our CFO are preaching to us. Make sure we do everything right first. So that way, if we do get a HAP penalty, we can say, well, we did everything correctly the first time. There are no ifs or ands. There's no, we should have done this or we should have done that. We did everything we could, and we are positive that we did everything we could. It just happened.
Mm-hmm.
So. It's interesting as you talked through that. I was checking out. I was Googling Forest Health and Forest General Hospital, because I was trying to understand a little bit about the governance structure. You actually there's some pros and cons to every type of entity. You're not for profit for sure, but it seems that you're governed solely by that board of trustees and a board of supervision. So you're kind of free to be making the decisions without as much maybe external forces. Does that maybe play into your ability to be so collaborative with other, or is that just straight up your leadership that's in the hospital?
Absolutely. I think it's both. I think it's our leadership inside the hospital, and it's our board of trustees and supervisors, because the board of trustees and supervisors, they have put together a C-suite of people that care about the patients, they care about their employees. They do everything they can to make sure we have everything we need to operate efficiently, to have high quality care, deliver high quality care to our patients, and that we keep them safe. Our CFO he's hands-on in the quality process, but he's also hands-on in his departments that he runs. He's not a guy that sits in his office and does nothing all day, but just worry about his financial numbers and then get the reports and then make decisions. He includes us in the decision-making process. Yes, it's ultimately up to him and the CEO and CMO, but he gets our input on things that we think would be beneficial to our department. He doesn't just say yes, no, yes, no, yes, no, without any input from us.
That's
So,
amazing.
and that's very important in any healthcare setting, because you have to, if you're in the C-suite, you have to be in contact with the people that are your boots on the ground, because you're not there every day. You don't know what they encounter on a day-to-day basis. You have a high level overview of what they do, but actually the tools that they need to do the job that you have assigned them to do, you don't really know what those tools are. So listening to your employees and making the best financial decisions, not only for the hospital, but for your departments, it comes from that communication. It comes from that listening and feeling like you're being heard. It's not, I mean, you can sit and talk to them, and sometimes you can talk to people and you can just feel that they're not paying you any attention. They're just like, yeah. But with these people, you actually know that they're paying attention to you, because he's listening to you. He's asking you questions that are pertinent to the things that you're asking him about, or the things that you're talking about. He's listening.
Right.
Even he
That's a
may not
blessing.
look. I mean, he may be like, you'll think that he's not listening because his eyes are this way, or he's doing this and he's nodding. He's not making direct eye contact. But when he comes up, he's like, so what you're telling me is, and you're like, that's exactly what I just said.
All right,
and yes,
yeah.
that is what I need. So yes, you were listening.
Awesome.
So, and it just makes a big difference to be in an organization that truly cares about more than just the bottom line.
What a great leader. Your hospital, especially with your no penalties going into 2025 for HAC and PSI, that's pretty amazing. You should be celebrated. So your hospital association in Mississippi should know your story so that they could celebrate you from that perspective. One final question, if you take just maybe 90 seconds to answer a question for me. So it sounds like as you talk through, your role and all the things that you do, especially related to quality and hacks and PSIs and things, and working with the quality team to achieve these goals. You're also the claims denial coordinator for commercial and Medicare Advantage, right? So
yes, ma'am.
That's your job. So it sounds that health information professionals are still wearing many hats in the facilities, regardless of the size, because you're 500 plus bed hospital, I believe. So you're a huge facility. So maybe take just, 90 seconds or so and talk a little bit about how maybe what you've learned in these quality, the quality work that you've done with hacks and PSIs. How does that impact how you does it serve you any in your primary role? Does it make you better equipped to respond to some of those DRG downgrades that you get?
Absolutely. Working with the PSIs, working with quality, it has taught me to read every single word.
Okay.
Because if you look at denials all the time, they're form letters. They just plug in diagnoses and plug in different things. And it's basically the same standard language. Whether they're denying sepsis, acute kidney injury, if they're denying respiratory distress syndrome in a newborn, or if they're denying metabolic acidosis, they're just going to type in, they're just going to put in those little blanks, what they need. And sometimes they even do that correctly, or they don't take out much of the standard form. So I'm like, okay, so these are mistakes. But when you're working with PSIs and you're reading those specifications, you have to read every single word. Because on PSI 11, it says patients that require reintubation, prolonged vent time, or a diagnosis of post-op respiratory failure. So it's not all three, it's only one.
Yeah.
If you have one of those, if you have a code on there for reintubation, and we ask this question to ARC, because they do have a frequently asked questions page. If you have any questions, or if you're concerned about any of those technical specifications, reach out to them on their website, and they get back to you faster than CMS. I will give them that.
Good. Because that's not a high bar. Thank you. That's not a high bar.
Well, that's true. But they are faster. They are a lot faster than CMS. So we reached out to them, and they were like, well, no, it doesn't matter if the vent flipped on. They were re-intubated.
Wow.
The patient coded, and they were re-intubated because they coded. It was a cardio, the cardiac arrest. They had to intubate them.
Mm-hmm.
Nothing to do with the surgery. But no, it happened within that global period for that patient. So if that patient had not had that surgery, would that patient still have had cardiac arrest? That we do not know. But we can assume if the patient had not had the surgery, they would not have had the cardiac arrest. So, but yes, it has taught me to read every single line. And I have found mistakes within those denial letters, those form letters they send out with the little blanks that they fill in. So it's taught me to be more scrupulous in what I read.
Okay.
It has taught me to look in places that I wouldn't think to look for exclusions, or look for, not exclusions, but look for ways to combat their denial. Mm-hmm. So it has taught me to be a lot more studious, a lot more careful to read every single line, because the doctor can put in one word and it changes the entire meaning of that sentence. Mm-hmm. We had so it was an op note that he said that the tumor actually penetrated the dura. It was a tumor that penetrated, that tore he didn't tear it. The tumor did.
It's important.
So, it's important. But the way he worded it, you had to read it a couple times to make sure that's what he was saying. Mm-hmm. So read multiple times. Don't just read through once and think you got it. Because I've had to read PSI 11 many a night. And I think I have dreamed about PSI 11 on a couple of occasions.
Oh my goodness. Well, Casey, thank you so much. As we close up here, I just want to say kudos to you and to Forest General, your team there, from your leadership down to the most minute detail of scrupulous reading and studious attention, for not having any penalties coming down the pike for you in 2025. That starts October 1st. That's amazing. Kudos. And also to the professionals or the students that might be listening to this, health information professionals and students that might be listening, learning something or being involved in an initiative in your facility will serve you. Even if you feel like it is not directly related to your role, you can learn, and it will make you better, more collaborative. It will build your network. It will teach you things, and you will just be a better version of yourself for yourself and for your organization and patients in this case. So Casey, thank you. It was great to meet you. Love the energy you bring, and love the detail with which you just schooled me, because I had been so far removed that I needed all that education.
All right. Well, thank you guys for having me on today. I really enjoyed our conversations. I hope I can meet you guys at AHIMA this year, hopefully.
Yeah, I hope so. That'd be great.
All right.
Great.
All right. Yeah. Good deal. Well, Shannan, it's been a blast. Until next time, my friend.
All right. See you next time.